Hello BMSA, my name is Danny Grave, and I am BMSA's Media Chair, and I will be tonight's host for Biweekly Rounds. We hope your semester is off to a great start. Please keep washing your hands and wearing your masks so we can flatten that curve. And tonight we will be having guest speaker Dr. Connor talk about his path to a career in the medical field, and he'll give some advice to future healthcare professionals. But first, here's a word from our officers.
Hi BMSA, welcome back to school. My name is Delaney Shu and I'm the new president for this school year. Just a friendly reminder to pay attention to the full video. Danny and the media committee have worked really hard on making this a good experience for you guys and letting you experience general meetings, and so has the guest speaker. So just be respectful of their time, pay attention to the meeting, and welcome back to school.
Hi, I'm Sarah Jones and I'm going to be your service chair this year. I'm excited to announce that we have a lot of new service events as well as several old ones. So you guys should really be on the lookout for a lot of our new online service events, as well as most of our events are going to be application-based this year. What that means is that you guys need to be on the lookout for events on our Google form at the beginning of the semester. A lot of organizations want application-based events because of orientations and COVID restrictions, so be sure to be on the lookout for those. They're a great way to form a small community within BMSA, as well as ensure that you'll be able to get your 10 required service points for the semester.
Hi, I'm Harrison Rennie, your Medical Discussions Chair. This week we'll be having our first Medical Newsletter News Hour event, Thursday the 24th at 8 o'clock on Zoom. Next week, the night of Tuesday the 29th, we'll be having Ethics Forum again at 8 on Zoom. Both of these events are bi-weekly, and they're a great way to connect with other BMSA members and still have some discussions even though we can't be in person. We'll also be having a Grey's Anatomy event on October 1st at 7:30 p.m. Be sure to sign up on the event sign-up form for these events so that we can send you a reminder email and let you know if there's any technical difficulties and we need to make some last-minute changes. Thanks.
Hey guys, my name is Aiden. I'm your membership chair for this semester. I just wanted to welcome all our new members and just remind you all that you need 50 points to be active this semester. You need 10 service points and 10 academic workshop points. If you have any questions about your points or feel you're missing points, you can always submit an appeal on our website as well. Thank you guys.
Get it almost every night. When that moon gets big and bright, it's a supernatural delight. Everybody.
Hi guys, my name is Abel Thomas. I am the treasurer for BMSA. My announcement is to pay for dues. They are due September 22nd at midnight when this video is going out. You can pay for dues by going to the BMSA website at bmsabu.com. Click on the dues tab and follow the instructions there. We're only accepting money through PayPal just to make sure that we follow the CDC instructions. Thank you guys so much.
Hello everyone, my name is Jessica and I'm one of your Global Health Co-Chairs. I wanted to highlight some of the amazing virtual workshops we have going on this week. First, we have medical terminology on Thursday from 7 to 8, and we have medical Spanish next Wednesday from 5:30 to 6:30.
Hello everyone, my name is Daniel and I am the other Global Health Co-Chair. We also have World Health Organization this week on Thursday, and also we have Global Health Outreach Workshop on Tuesday, October 6th, so right before the general meeting. Thank you.
Hi guys, I'm Jasmine Crabb. I'm BMSA's Community Outreach Chair, and we don't have any events coming up until the third week of October, but be on the lookout for them at that time. I just wanted to introduce myself and say that I can't wait to meet you all.
Alright, now that you heard all about those great events going on these next 2 weeks, let's hand it on over to Cameron and our guest speaker, Dr. Connor.
Hello, and welcome back everyone from home. My name is Cameron Campbell, and I am your new Vice President for BMSA. To our returning members, the general meeting may look a little different. You're at home, and I'm on the screen, and that is due to BMSA's steadfast moral obligation to help flatten the curve and protect our neighbors. And in doing so, we had to cancel our general meetings in person. But we did not want to deprive you of the invaluable lessons and experiences from these medical professionals to give to our future medical leaders. And so with that, I would like to introduce you to our guest speaker today, orthopedic surgeon, sports medicine doctor, Chad Connor. If I went through all of his accolades, we would be here all night. But without further ado, Dr. Chad Connor.
All right, thanks, Cameron. Guys, excited to be here tonight. Glad that you could have me. Hope there's something that's useful tonight that you can learn, or if you're online watching, that may spur some interest and give you some reason to maybe keep studying and keep moving forwards in what you're doing. So Wake Orthopedic Sports Medicine is our initial name when we came to town. We're now Ascension Providence Orthopedics and Sports Medicine. A little bit about what Cameron said. I grew up in Dallas. I went to the University of Minnesota. There I did gymnastics. There's me trying to do a high bar routine. From there, went to UTMB. Met my wife there, Catherine, and got married in medical school, third year. And from there, went out to SCOE, Los Angeles, had a few babies along the way. And in 2010, we came back to Waco, Baylor Bear Country. Joined Wake Orthopedic and Sports Medicine. We merged with Ascension Providence Orthopedics and Sports Medicine in 2019. I got 4 kiddos now. They're getting a little bit older. They're doing great. All right, so why orthopedic surgery? Let's see what we got here. Oh, it's fun. We enjoy taking care of patients. A lot of people have done statistics, and to me, it just made sense. That's the only kind of doctor I really understood when I was growing up, and so that's what I wanted to become from high school, and went to college, did pre-med, majored in business, and came to be that. So enjoyed doing that. So one of the initial start with a short case, give you an idea. 16-year-old female injured knee playing volleyball. She had swollen knee. She had decreased range of motion. She had a positive Lachman's and anterior jaw. Anyone here know what the Lachman's means? Nope, maybe. So that's concern for what? ACL, right? Strong work. So look at the knee anatomy here. You can see this is some of the stuff we work with daily. There's the ACL there. It's important to learn your anatomy. It's one of the neat things about orthopedics. Find you like your anatomy. Orthopedics, maybe something. Lachman's test, 20-30 degrees. You can check the ligament for the ACL. That's what you'll often see them do on the on-field Lachman, we call it. It's not just because you want to look cool as a sports medicine doctor out there examining the athletes. That's actually the best time you can get a feel if it's torn or not. In about 30 minutes or even 15 minutes, the knee will be swollen and he'll be guarding. You won't be able to tell, but right after the injury, you can almost immediately know whether the ACL has been torn. This is a short video. Perhaps it's short. And we'll take a look through. This just shows some of the anatomy of the knee. We can look around. That's the kneecap up above. Probably 80% of what I do, we get to do through the scope, which is great. You get magnified view of what you're doing, and allows you to see the anatomy very clearly. One of the things we do with the kneecap is we want to see how it tracks down the femoral trochleus. So we let the water out, and we'll bend the knee down and let that move. As we do that, let's see if I can fast forward a little bit. We'll then take a look around the rest of the knee. This is the meniscus right here. You may have heard of someone tearing their meniscus, and right there, that's the torn ACL. So we can see there with the picture. We'll skip ahead there, get another view of the ACL. And then this is us getting ready to prepare it. We use this radio frequency device. We go in and we prepare to place these tunnels to fix an ACL. We can prepare the bone and get rid of the old ACL that's not doing anything anymore. Then we take out a little bit of the bone here to give it more room for the new ACL. Once we do that, then we fix it. We put the new graft across. We use this little endo button here that flips on the outside of the bone. That helps secure it on the femur. Then we put a screw and sheath through the tibia. So just a little case of kind of what we do on a day-to-day basis there with the surgery. Tonight we'll talk a little bit about what orthopedic surgery and sports medicine is, define typical work week and day, key steps if you're interested in doing orthopedic surgery to help you along that way. We'll talk about what it's like in residency and then recognize the best parts of orthopedic surgery and maybe the less glamorous, and then why medicine, and then if there's any time, we may have a few other cases. So orthopedic surgery is treatment and maintenance of the musculoskeletal system. It's not just sports injuries. We see fractures, and as you can see here, this was when I went to Africa about 6 years ago. Patient we saw there, he was treated by the medicine doctor, the medicine man, for 2 weeks with a bone sticking out of the knee. Turns out that did not fix it. And he came to us with pus on the knee. We washed it out. We put an external fixator on, like you can see there, and lined the bones back up and hope to get him well. Said lots of prayers. So other things with orthopedic surgery, you saw the ACL a minute ago, right there. And then we do sideline coverage. That's of my middle son, Grayson. He's now 11, but from the early time they'd come and go to the football games with us and have fun doing that. Other things we do is non-operative treatment. Not everything surgery, although we enjoy surgery. We also like getting patients better without surgery. One of these things, does anyone know what the problem is with that person right there? All right, so that's called the IT band. So she's got an IT band strap on. She's doing some IT band stretches, and a lot of times we'll see that in runners that run a lot or cyclists, and so we can help them get better with that. So typical work day, usually start about 7 a.m. I'll start surgery, get there about 6:55, meet the patient, and roll back. Usually in the afternoon, we have clinic at 1 o'clock, and then 6 o'clock, we'd like to be heading home. Always a little variable, and you can, as a surgeon, most times you can adjust your day as you need and want, but we're typically pretty busy. You always want to remember the finer things of life. Enjoy the sunsets, enjoy times with your kids. That's my youngest son there, back when he was playing doctor. And then and that's my oldest son, who's now 13. And then we like to do Bible time at night, and there's Grayson with his little stuffed animal. Some days, though, it varies. You may have to get up and see patients in the hospital and get there at 6:15, do surgery at 7, lunch, clinic. Then maybe you're on call. So grandma goes into the ER with a broken hip. You're on call. They call you at 6 o'clock, and so then you go and do the surgery and put grandma's hip back together with a rod or a new hip replacement, and then you may get home at midnight. So my typical work week currently is do clinics all day, Monday and Tuesday. Wednesdays I do all day in the OR, and then Thursday mornings I do clinic, Thursday afternoon surgery, then Friday morning surgery, and Friday afternoon clinic. We're on call about every fifth night, weekends, every 5 weekends, and used to take about 4 to 6 weeks of vacation. Now that's probably about 5 weeks now. Sometimes when you merge with a big corporation, you don't get as much. But 1 week of meetings a year, usually that's a long weekend, a few days. And then I try to go teach a course. I teach hip arthroscopy, usually every other year at our learning center in Chicago for the Arthroscopy Association. We always try to find time for date night. An ideal week, me and my wife try to go out on Wednesday night. Well, actually, on an ideal week, I'll get out of surgery at 3 on Wednesday, and then go ride my mountain bike until about 5:30, then go on date night, and then go home. So it doesn't always work that way. Last week I was in the OR till 5:30, and then went to date night. But you just do your best. So if you're still interested, anyone still interested in the room? In the room of 3, 4? So, and online. So what's important? Well, I'd probably say the first thing is grades. Y'all probably heard that before, that grades and your MCAT score are basically kind of filters. If you don't have the grades or you don't have the MCAT score, it makes it much more difficult. If you have one, not the other, better. Have both, much easier. Then they can actually look at who you are and what you do and what you're going to bring. So it's the first most important thing is your grades, because if your grades aren't high enough, you're It's really hard to get up the hill to get seen, get noticed. That being said, one of my first take interns, and one of my first Baylor intern, he's took him 4 tries to get into med school. He finally did on his 4th try, and he had a pretty low GPA from his first freshman year, but he kept working to improve his application. After undergrad, he went and did the master's program in Fort Worth, and then did really good for his GPA. So you can do things, but obviously it took him 4 years. It's a long time, but he's now finishing up med school and applying to orthopedics now as well. So that's a pretty neat story. But the easier way is just get good grades first, especially if there's any freshmen out there. Study hard this semester. MCAT, you'll want to do well in that as well. Volunteering, I would say, is next. If I had a student, I'm not on admissions committee, but if I was, and you had 2 students with the same grade, same MCAT score, and one student volunteered 200 hours at Mission Waco, and another student shadowed 200 hours with me, I would probably pick the student that volunteered for 200 hours versus the one that just shadowed for 200 hours. So, because it shows you're thinking about others, as perhaps you're just thinking about getting experience yourself. Shadowing is a good thing, and you should get some experience in the medical field. Helpful if you maybe have some volunteering in the medical field, I would think. But I think showing that you have a heart for others is what they're looking for. And then doing enough shadowing that you know that you like this and this is what you want to do. Because it's a long road, but it's very, very rewarding. Make use of your med school advisors. They'll help give you advice on classes and such and what you need to do. And if they say you're not qualified, you're not going to make it, then you have to decide if you are, not them. But they may know what they're talking about. They've been doing this a long time. But it doesn't mean you give up, just maybe a big battle. And you get into medical school, then if you want to go into orthopedics, there's same thing again. Looks like it's grades, test scores, and then this time there's research and such. But that's gonna help you along the way. Once you get to where I am, the grades thing finally goes away. Nice. But by then you're used to getting A pluses, so that's what you do in life, still surgeries and such. Something called 3A's. Every student I have come works with me, I try to teach them this. It's called availability, attitude, and ability. You can have 2 out of 3, but you got to have at least 2 out of 3. 3 out of 3 is important. So you either got to show up, you got to have a good attitude, people like you, and then third is ability. So you got to have at least 2 out of 3. Go for 3 though. So for orthopedic match, 99% of the spots match. So that means in the country, there's not many really open spots. Everyone takes the spots that are available. Usually, I haven't checked any updated data on this, but it was at least 2 applicants per available position. So quite a few people want to do orthopedics, but it's the best. So no, I'm just kidding. It's the best for me. I like it. Initial screening, they again look at scores. USMLE is kind of like the MCAT is in college. It's your board scores. It's a national test that kind of compares you to everyone else. AOA is a organization you get into in your junior year. I think it's top 2% and maybe top 10% your senior year. So that helps to simulate that you're doing good at grades. Then there's away rotations and your class rank, letters of recommendation, research, interview performance. Away rotations is a way when you get into med school where you can go and visit a program, see if you like it, and most importantly, show them that you're and you're smart and you're fun to be around and that you got the 3A's. And so that's one of the things that's real helpful for getting in where you want to go. You should plan on doing at least a couple of those if you're interested in orthopedics and for most other competitive residencies if you're interested in that. So what's residency like? So you did college, now you did med school, now you get residency. So 4 years of college, 4 years of med school, and then residencies next. So residencies, basically what I do now, but you don't know anything yet. So you do everything, plus you read and you learn and you read and you work. And when I was there, they just started instituting what was called the 80-hour work week, which meant you couldn't work more than 80 hours. They've pared that down even more nowadays. And then it was 80 hours a week and not more than 30 hours at a time. And so that's even less now, which is probably a good thing because it was pretty tiring. But that didn't include the reading and the learning. So that was just actually in the hospital parts, the reading and learning you did when you got home. So it's pretty tough, but it's amazing when you're interested in doing what you're doing, you like it, you enjoy it. It's like, I don't know, it's like watching a good movie. You don't want to turn it off till it's in. Or reading a good book. It's exciting, it's fun, and you enjoy it. It's hard work, but it's very rewarding. You're getting to do, learn neat stuff and do what you enjoy. So just like anything in life, if you enjoy it, it's going to be good. If you don't enjoy it, it's going to be difficult. So make sure you enjoy what you do in life. That's me and my oldest son when he was smaller. So we had our first son when I was well, it's been a while now. I guess he's 13 now. So we were probably third-year resident, and my wife was a second-year pediatric resident. And so we were in Galveston, and we got to go to the beach and have some good times. And so you can do it. I don't know how my wife did it because she did all that. Plus she breastfed, and she was getting up at 4:30 in the morning to breastfeed and pump and do all that, and pretty tough. But we hired a nanny, and she really helped us. And she said, I need more hours than I'm getting at daycare. And we said, okay, how much do you want? I'll take as much as I can get. And I think she worked 80-hour work weeks too. So you should never, if you have kids in medical school or residency, you need to get over your problem of spending money on babysitters or even college. I guess some kids got kids in college because you can't do it without the help. So what are the best parts of orthopedic surgery? Helping people get better, performing surgery, diagnosing complex and simple problems, and for me, sharing Jesus. For me, it's really my ministry. It's what I get to do to bring just the heart that Jesus has had for me to others, and it's a no better place to do that than to be able to help with their healing and share that He loves them. The worst, paperwork. So it's always paperwork. It never goes away. You'll work to get caught up, and then the next day you'll be behind again. And so that's the hard part. But just it doesn't go away. It's just part of what it is. Me, I hired a PA about 5 years ago, so they helped me with that. And so if anyone's interested in PAs, are y'all medical students only, or all health fields? All, yeah. So physician assistants has really come a long way in the last decade or so, especially even more. Now, I've worked with a PA for 5 years, and it's fantastic. I think it's really a win-win for our patients. They get better care because right now I haven't had a chance to look at any message today, but I'm sure Elizabeth has checked the message and given some needed it, and so it's really good to have a good team dynamic. Someone that surgery, we do the surgery together, do all the surgeries together. They know exactly what we're doing, and so it's allows surgeries to go smoother and easier, which is better for the patients. Plus, it allows us to be able to see patients in the clinic and get people in faster and sooner. So why medicine? Well, you'll always be needed. They haven't figured out how to, Google hasn't figured it out yet. They may figure out how to do basic things, but they're ways away from doing surgery. You can get paid for this hobby, and you can start and finish most tasks in a single day. When I was in college, I actually was a finance major, was interested in investment banking and as well as medicine. But I'm glad I figured out that I wanted to be a doctor and chose that path because I figured out that I don't like things hanging over my shoulder. So if you like stuff and projects that last a long time or forever type thing, then maybe family medicine, where you're always working on the patients, trying to help them get better with their diabetes and stuff like that. For me, I do better with someone's got a bum shoulder and we're going to go fix it and get you better. And then we'll follow them over the 6 months of getting better. But that fits my personality better, fixing things. And you get to make a clear difference in people's lives on a daily basis, which is nice. All right, words of advice. Has anyone got any advice lately? All right, so these are some of mine. Live your life to the fullest in each season of life. It's so often you can say, well, once I get there, well, once I finish residency or once I finish fellowship, then I'll do X. Or once I finish residency, then I'll spend some time with my kids. Or once I do this, and once will never come. And so I'm a big believer in that you want to live your fullest life in each season. You're in college right now, enjoy it. Enjoy the time you have, and when you're in the next season, enjoy that time, and live each part to your fullest, because it doesn't come back. It doesn't go backwards; just goes forwards. Don't put life on hold until you get there, wherever there is. Yeah, that was my saying. Do your best, forget the rest. I'm getting old now. P90X. If anyone's heard of that old program, that's where they said that. It also comes from the Bible as well. I think he stole it. So let's see, how are we doing on time here? A few more minutes. You want to see one more shoulder arthroscopy part of it? Okay. So this is the shoulder now. We do a lot of shoulder. A lot of people tear the rotator cuff. You can see up here. And you've got the different muscles around. This is the labrum here where the ligaments attach. So we'll go through this shoulder surgery a little bit. This is a gentleman that had dislocated his shoulder. And so it's a little bloody right now because we just stuck the camera in right away. And what we need to do is make a portal. And so while we're looking inside, we bring this needle in from the outside to figure out what pathway we want to take. And then once we do that, and we've got fluid that's flowing through, that allows us to see, and now you can see the picture is much more clear. That long structure you see right here was the biceps. And then we'll take a look around. You can see a little bit of the fraying of that. That's called your superior labrum. If you've heard of anyone ever having what's called a slap tear, that is what that is. And so we'll take a look around the joint. You can see this is the socket. The patient's laying on his side when we do the surgery. And then up above, you can see the ball right up there. And then down here, the capsule ligaments down below. You can see a little scuff right there where he dislocated his shoulder. That's called a Hill lesion, but it was pretty minor. And then up here, you can see there's a rotator cuff right there. And so this patient's nice and young, so he's got good vasculature to the rotator cuff, and the rotator cuff was intact. And so once we see that, let me skip ahead a little bit, we make our next portals, and then we will come in with our cannula here, and that allows us to have two working portals. So we'll have one portal to look from, and then we'll have two portals to pass instruments and sew and drill and put anchors in. So you'll see us bringing that in just like that. Once we've got that in, we put another cannula in the back. The color signifies the size for us. These are kind of a flexible, stiffer type rubber cannula. And now we can bring our probe in and we can take a look at the damage. You can see how that tissue is not attached right there. And that's called the Bankart lesion. And that's the labral tear in someone's shoulder. When that's not attached, your arm comes up like this, it'll dislocate out of the socket. And so as we do that, we'll come in, we'll have to complete the tear. So we want to get rid of all the scar tissue that's there and freshen the edge so we have nice, good exposed bone. And then we clean the tissues here with a shaver that's frayed. Shoot forward. And the next thing we do is we put anchors in. So you can see here's one of the anchors going in. We'll get that lined up, and we'll punch that into the socket. And that's a bioabsorbable anchor. And so it's made out of biocomposite material that has calcium and some other ingredients that allows it to dissolve over probably 2 to 4 years, depending on the patient. And so we pass those anchors, and we use a device like this. It's called a spectrum sewing device, and we can actually come through and sew the labrum back. So we'll paste this through. Then once we get that through, we'll feed this little black kind of suture or polyethylene wire through. We'll reach in with our grasper, pull that out, and then once we have that wire pulled out, we'll take the blue wire, the blue suture, and we'll feed it through the black and then pull it through the back of the labrum there. And then once we do that, we can then take the other sutures out of that cannula that we're operating through, and then we can tie it with an arthroscopic knot. So you can see here, here's our knot pusher here, and we use this to tie knots inside the shoulder. We tie the knot outside the shoulder. I use a knot called the SMC knot. It's much like a little bit like a fishing knot, but it's a little more complex because it slides and it locks. And we use this knot pusher to push the knots down. We finish it with what's called half hitches, and then we come in and we trim the suture off with that little suture trimmer just like that. And so that's a good example. We'll put more anchors in here. And then when we're done, we'll sew. And we'll work our way all the way around, getting everything repaired so it's all the way fixed. And when we're done, you can see we've got everything nice and secure to the bone. So it acts almost like a bumper for the shoulder. Reattach the ligaments so it stabilizes the shoulder so this patient can get back to their sport. So I think that's about 30 minutes if y'all want to do some questions. And right, so understandable. That's the normal response from any student I have coming to the OR. Look what we're watching. That was the normal response I had first time I looked in the OR at that as well. And so the good thing is there's books and videos, and so you can learn to figure out what the anatomy is, because there's one thing to look at anatomy in an anatomy book when it's just opened up and you're looking at the muscles and tendons. But then there's something called surgical anatomy, which is the anatomy that you see when you're doing arthroscopic anatomy, or there's anatomy you're seeing on a certain surgical approach to get to a certain area of the body. And so that's more of a applied anatomy type understanding. And so, but once you've done it many times, you'll know exactly what you're looking for and what doesn't look right and where to go. So.
Good. So I assume that just comes with experience, because looking at that looks much different, a shoulder in a book, than what you just showed me there.
Right.
There's a camera 1 millimeter away from that bone, and so I guess with experience that just becomes normal. Looks like normal to you.
Yes, sir. Yes, sir.
So what other specialties did you consider, or did you always know you wanted to do orthopedics?
Well, I was pretty convinced from my time in my internship in orthopedic surgery, and then when I got to med school, I did a little bit of shadowing and further was interested in that specialty. What you find when you get to medical school is you get to try out all the different specialties for the most part. You do dermatology, you do GI, well, I may have not done GI, but you do general surgery, you do OB-GYN, you do family practice, internal medicine, cardiology. So you get a good exposure to all the different fields. It's helpful, so when you are doctoring whatever specialty in, you have an idea at least what other problems the patient may have and who to call to know what to get things fixed. And so you really get to decide what you like and what you enjoy most. The key to doing well is to like everything while you're doing it, and then when you're done, you can decide if you liked it or not. That helps you do well on your rotations. I didn't really have much else that I was really in love with. I probably could have done emergency medicine as my backup. I didn't really have a backup, but I figured I could do anything for 13 shifts a month. And so.
Awesome. Next question.
And the next one is, do you ever do more than one surgery in a day? Or how many do you do a week?
Okay. So, in regards to surgeries, do you ever do more than one surgery a day, or about what's your typical week for surgeries looking like?
Sure. We hope most days to do more than one surgery a day, because if you're only doing one surgery, that means it's a really long, complex surgery. And you do those when they need to be done, but you don't hope to do that every day. So usually, like on a Wednesday when I'm in the surgery all day, usually I do 4 surgeries. Most surgeries are anywhere from average of probably an hour and a half. To go in and scope someone's knee and take out a torn meniscus, about 30 minutes. To go in and scope someone's hip, to repair a labrum and reshape the bones. It's usually an hour and a half to 2 hours. Sometimes shorter, sometimes a little longer, depending on what the anatomy is that you encounter.
Okay, and then the next one, that question about like, what's it like going from school and undergrad and then transitioning to school and medical school? I thought that was a good one.
Okay. So what would you say the transition is like from undergrad to medical school for you?
Sure. So for me, I was in gymnastics in college, so that was about 30 hours a week of training and working out. And I probably did, maybe on a good week, 6 hours a week of studying. When you get to med school, it was pretty much flipped. We did about 25, 30 hours a week of studying, and then maybe 6 hours in the gym. I think it's important to work out, and it's important to stay healthy and keep doing that. You just can't probably get in 30 hours during med school.
Can imagine.
Another question about studying?
What studying? No, studying's boring. Let me think. Do you like maybe a favorite procedure or a favorite,
Yeah, let's see. Yeah.
I don't know, or something?
Yeah, that works. Cameron, go for it.
Yeah.
Most fun procedure, I guess, something like
Most
that.
fun procedure.
Yeah.
So, as an orthopedic surgeon, is there one certain procedure that you like to do the most, that you get excited to do, that you like?
Sure. I like everything with the arthroscopy probably the most, and so that's what I get to do 80% of the time, so I'm very thankful for that. I got to do a fellowship where I got to learn from some of the best guys in the world at it, and so I enjoy working through the camera. As you see, when you have the visualization, everything's so clear and detailed. It allows you really put the anatomy back just the way you'd like. One of my favorite surgeries is that Bankart repair, the shoulder repair that we showed. And then ACLs are fun as well. It's always fun to get folks that can't do sports at all, but you tear your ACL and get them back to doing what they want to do.
Very cool. Going off of that, what was the very first procedure that you ever did as an orthopedic surgeon?
So first procedure I ever did was probably as a third-year med student. There was a patient of ours from the Texas Department of Criminal Justice, and he had a plate and screws in his ankle from when he had broken it previously, and he needed the plate and screws out. So the resident that was there with me, he let me make the incision and dissect down to the plate, and take the plate and screws out, and then close it up. So that was my first surgery I ever got to do. The whole thing on that was just fantastic at that point in my career.
That's great. Glad that you remember that as well. I'm sure that must stick with you, remembering your first surgery. Okay, I just wanted to say thank you again so much, Dr. Connor, for taking time out of your busy schedule to come here and educate the future medical leaders of BMSA. And thank you as well at home for watching and tuning in. And hopefully you learned something. And we will see you here again in 2 weeks. Be safe, keep yourself safe, and keep Waco safe. Thank you.
All right, guys, that's all for us tonight. Go ahead and comment down below if you have any questions for the officers. Fill out that Google form to make sure to get your points. Go ahead and subscribe and follow us on all social media at BMSA_BU to keep up with all the fun. Thanks for watching.